Now, the types of concomitant squint. Three common types of concomitant squint are the convergent squint, divergent squint, and the vertical squint. Convergent squint. The convergent concomitant squint or esotropia denotes the inward deviation of one eye and is the most common type of squint in children. A convergent squint may be unilateral, in which the same eye always deviates inward and the second eye is always taking up the fixation. Alternating convergent squint, in which either eye, when one eye takes the fixation, this becomes convergent, and when this takes the fixation, this becomes convergent. This will be an alternating convergence. Now, infantile esotropia or congenital esotropia is characterized by following features. What is the age of onset? Is usually 1 to 2 months of age or may occur any time in the first 6 months of life. The angle of deviation is usually constant and fairly large, more than 30 degrees. Fixation pattern. The binocular vision does not develop and there is alternate fixation in the primary gaze and a cross fixation in the lateral gaze. This is a photograph of a 5-month-old with congenital esotropia. This again photograph of a child taking fixation with the left eye and the right eye is showing convergent squint. So this is the alternate convergent squint. When right eye is fixing, the left converges, and when the left is fixing, the right eye converges. Infantile esotropia, amblyopia develops in 25 to 40% of cases. Associations include inferior oblique overaction, dissociated vertical deviation, and a lateral horizontal nystagmus. Surgery is the treatment of choice for an infantile esotropia. Amblyopia treatment by patching the normal eye should always be done before performing the surgery. Recession of both the medial rectus is preferred over unilateral resection procedure. When you recess the muscle, you weaken the muscle. Recession of medial, क्योंकि convergent squint है, तो overaction है medial rectus का, तो you recess the medial rectus. Time of surgery would be between 6 months to 2 years of age, preferably first year of age. Now, accommodative esotropia. It occurs because of overaction of convergence associated with the accommodation reflex. Accommodative esotropia is the most common type of squint in children, and when esotropia develops around 2 to 3 years of age, it is most likely to be accommodative. It's of two types: refractive, non-refractive, and mixed. The refractive accommodative esotropia usually develops at the age of 2 to 3 years and is associated with high degree of hypermetropia, that is +4 to +7 diopters. And mostly it is for near and distance and fully correctable by the use of spectacles. This is the fully accommodative esotropia. Non-refractive accommodative esotropia is caused by an abnormal accommodative convergence upon accommodation ratio. This may occur in patients with no refractive error. Here, the esotropia is greater for near than for the distance and is fully corrected by bifocal glasses and add +3 diopters for near. Myotics may be useful in younger children. Mixed accommodative ESO is caused by combination of hypermetropia and a high AC upon A ratio. ESO for distance is corrected by correction with hypermetropia, and the residual ESO for the addition of +3 lenses. Now, acquired non-accommodative esotropias. This group includes all those primary ESO deviations in which the amount of deviation is not affected by the state of accommodation. This includes essential acquired or late onset ESO, acute concomitant ESO, cyclic ESO, nystagmus blockade syndrome. Essential acquired or late onset ESO. It will be the most common variety of concomitant convergent squint, typically occurs during first few years of life, anytime after 6 months of the age. Basic deviation will be equal for distance as well as for near. convergent squint test, so it will be convergence excess type, in which the deviation will be large for near and small or no deviation for distance. Divergence insufficiency type, in which it will be more for distance and includes the search. Sensory esotropia is resulting from monocular lesions in childhood, which prevent the development of normal binocular vision. Similar cataract है अगर एक साइड पे, या severe congenital ptosis, aphakias and isometropias. This will lead to a sensory esotropia. Consecutive ESO, when you're doing a correction for EXO and you cause an ESO, that is known as a consecutive ESO. Now we come to divergent squint. EXO in India is more common as compared to ESO. Congenital EXO, it is rare, usually present at birth and almost always present at 6 months of age, characterized by fairly large and constant angle of squint and alternating with the homonymous fixation. Amblyopia present in minority of cases. Both DVD associated infantile exos are less. Primary exo, it may be a unilateral, similar to convergent squint. It can be a unilateral exo or it can be an alternating divergent squint. Intermittent exo, age of onset 2 to 5 years, deviation becomes manifest at times and latent at other. Precipitating factors are bright light, fatigue, ill health, daydreaming. Sensory testing reveals good fusion, stereopsis and usually no amblyopia. That is intermittent exo. Now the constant exo. If not treated in time, the intermittent exo may decompensate to become the constant exo. Primary exo is of 3 types. It will be convergence insufficiency, so this will be greater for near. If it is of divergence excess, it will be greater for distance and non-specific type. Intermittent exo is a large exophoria that intermittently breaks down to form the exo. The intermittent divergent squint usually presents at 1 year of age. You get a large exo, high degree of stereoacuity and non-surgical treatment. It usually, the non-surgical treatment does not work well. Part-time monocular occlusion of the dominant eye 3 to 4 hours a day can be done. Prescribe minus 1.5 or minus 2.5 spherical more than required by cycloplegic refraction. Orthoptic exercises can be given. Surgical treatment of IDS would be bilateral lateral rectus recession. Divergent squint is the symmetrical surgery is preferred over monocular resection procedure. Sensory exo, it is a constant unilateral deviation which results from long-standing monocular lesions. And common causes include traumatic cataract, corneal opacity, optic atrophy, anisometropic amblyopia, retinal detachment, and organic lesions. Consecutive exos when you're doing surgery for ESO, but residual exo is a common occurrence and usually occurs late, several months to years after the initial surgery. For a residual exo that occurs after lateral rectus recession of less than 6 and consider re-recessing. These are the instruments used for the squint surgery. Evaluation of a case of concomitant squint. A meticulous history should be taken. Age of onset, duration, what is the mode of onset, gradual, any illness is there, examination, inspection has to be done, ocular movements should be tested. The ocular movements are going to be normal in all the cardinal positions of gaze. You have to test the pupillary reaction, then media, fundus examination, testing of vision, then direct cover test, cover uncover test, like we did for the phoreas. You have to cover the eye and you have to look for the movement of the eye under cover, then alternate cover test to see for the primary and secondary deviation. And in concomitant squint, we know the primary and the secondary deviations are the same. Then Hirschberg corneal reflex test. The patient is asked to fixate at a point light held at a distance of 33 centimeter, and deviation of the corneal light reflex from the center of the pupil is noted. The angle is 15. If it falls on the border of the pupil, then it will be, if it falls on the limbus, in between the pupillary margin and limbus is 30, 15, 30, and if it falls on the limbus, then it is 45 degrees, and here it is 70 degrees. The 0 is the Hirschberg corneal reflex test for testing the amount of the squint. Then the prism and cover test. Prisms of increasing strength with apex towards the deviation are placed in front of one eye. The patient is asked to fixate an object with the other. The cover and cover test is performed until no recovery movement of the eye under cover, and this will give you the amount of deviation in the prism diopters. Kimsky's corneal reflex test. In this, the patient is asked to fixate on a point light, and the prisms of increasing power with the apex was the direction of the manifest squint are placed in front of the normal fixating eye till the corneal reflex gets centered. The power of the prism required to center the light reflex in the squinting eye equals to the amount of squint in the prism diopters. Testing for the grades of binocular vision. Normal binocular, 3 grades, there are the sensory anomalies, eccentric fixation. A few common tests for the Wirth 4 dot test as performed. Now this is the Wirth 4 dot test. There will be 2 green dots, 1 red and 1 white dot, and a patient with the left eye suppression, and you ask the patient to wear glasses with a red filter in front of the right eye and green filter in front of the left eye. And if the right eye dominance is there or a left suppression is there, the patient will see 2 red, and if there is a right suppression or a left dominance, the patient will see 3 red, 3 green, and a normal individual will see all 4, and patient with diplopia will see 3 green and 2 red lines. Now, test for fixation. Now, it can be tested with the help of a visuoscope or a fixation star of the ophthalmoscope. The patient is asked to cover one eye and fix the star with the other eye. Fixation may be centric on the fovea, eccentric, then it can be parafoveal, macular, the parafoveal fixation, macular or paramacular or a peripheral fixation. Types of fixation. After image test, the right fovea is stimulated with a vertical and left with a horizontal bright light, and patient is asked to draw the position of the after images. This is a synoptophore for testing the grades of the binocular vision. Details of synoptophore not required for undergraduate level. And neutral density filter. The visual acuity is measured without and with the neutral density filter placed in front of the eye. In case of functional amblyopia, visual acuity usually improves with the neutral density filter, and in organic amblyopia, it will be reduced. So what will be the treatment of concomitant strabismus? It will be to achieve a good cosmetic correction if there is any visual error, to improve the visual acuity, and to maintain binocular single vision. So treatment modalities will be spectacles with full correction of refractive error should be prescribed in every case. It will improve the visual acuity and at times may also correct the squint partially, completely if it is in case of accommodated squint. Occlusion therapy will be indicated in cases of amblyopia. After correcting the refractive error, the normal eye is occluded and the patient is advised to use the squinting eye. Occlusion helps to improve the vision of children children below the age of 10 years. Squint surgery is required in most of the cases to correct the deviation. However, it should always be instituted after correcting refractive error, treatment of amblyopia, and orthoptic exercise. The basic principle of squint surgery are to weaken the strong muscle by recession, that is shifting the insertion of the muscle posteriorly, and to strengthen the weak muscle by resection, that is shortening of the muscle. The type and amount of muscle surgery will depend upon the type and angle of squint, what is the age of patient, what is the duration of squint, and visual status. Therefore, degree of correction versus the amount of extraocular muscle manipulation cannot be mathematically determined. Treatment modalities are 1 millimeter of resection of medial rectus will correct about 1 to 1.5 degree, and 1 millimeter recession will correct 2 to 2.5 degree, and 1 millimeter of resection and recession of lateral rectus will correct 1 to 2 degree. The maximum limit which is allowed for medial rectus resection is 8 millimeter, recession is 5.5 millimeter, and the corresponding figures for lateral rectus are 10 and 8 millimeters.